professor in MAMC New Delhi from 2017 to till date. Presently, she is an associate professor at the Department of Biochemistry, MAMC Bahadur Shah Zafar Mar, New Delhi, India. Her interest includes on the oncology and yoga field. It's my honor to welcome you, ma'am. So hope you'll be judging this session and all the participants will gain more knowledge from you. Thank you.
Yeah, thank you. Thank you so much for the introduction. And hopefully I will be learning from your students, I think so. Thank you.
Anisha, can you read the rules and regulations?
Ma'am, could you just share the screen for me?
Just a second. Yeah. Tanisha, can you see now? You are muted. Okay, no problem. The rules and regulations for the final posters are for the presenters who are presenting today. It should be a clear and concise visual presentation of the abstract, and only one presenting author should be allowed. The demonstration time is 3 minutes. You can extend up to the maximum of 5 minutes, followed by a question and answer session from the judges and the audience. So the presentation will be live on Zoom with the judges and audience. You will be asked to share your screen for the presentation. If you don't want to do it yourself, the moderator can do it for you. So we can do it. Please turn on your webcam so that the audience can see you during the presentation and use a virtual background given for you. Yeah, thank you. Maheshwari ma'am, can we start with the presenters?
Yeah, sure. I'll mute myself, and during the question answer session, then I'll unmute myself, right?
Yeah, yes.
Okay, yeah, sure.
Ma'am, should I call out the first one then? Sorry, I got disconnected for a while. Okay, yeah. So our first presenter is Dr. Simran Thakkar. Are you there in the meeting, Dr. Simran?
Yes, ma'am, I'm here only.
So you can start presenting, and then once you start, I'll tell you when your time starts.
Yes, ma'am.
Dr. Simran, are you there?
I think Dr. Simran has network issues and she has logged out. So I think we should move on to the next participant for now. Dr. Survase, are you there in the meeting? Okay. Dr. Simran is back. Are you there? Are you able to present your screen
Yes,
now,
I'm
Dr.
able
Simran?
to. Hello.
Simran, I think we have
Yes.
network issues.
Just, yeah, the screen is completely black. You cannot see the poster. Let's do one thing.
Am
You
I
take some time.
audible?
No, your voice is cracking a lot, Dr. Simran. What we can do is you can take.
Yeah. Okay, ma'am, can I start my presentation? Yeah. Ma'am, can you see my screen?
Yes, it's visible now. What you can do is you can switch off your video camera because you seem to be in a low network area. Your voice is
Okay.
cracking a little.
Okay, ma'am. Okay. Okay, can I start the presentation?
Yes.
Yeah, sure.
And you're
Yeah.
Okay. Okay. I'm
now. Yeah.
Okay, good evening, one present. I'm presenting a case of a 13-year-old male who presented with the complaints of jaundice, vomiting, intermittent high-grade fever. On eliciting, he had a history of recurrent blood transfusions with a frequency of once every 6 months. On examination, he had pallor, icterus, with a massive non-tender splenomegaly. On investigating, his peripheral smear revealed mild anisocytosis, macrocytosis, target cells, and spherocytosis with basophilic stiffening. His reticulocyte production index was 10 with an MCV of 132, MCH of 36, and MCHC of 27. His investigations was as following. With an anemia of 3.3, total leukocyte count of 18,000, platelet of 3,45,000, with an indirect hyperbilirubinemia of 12.6 and a direct bilirubin of 1.6. His fever profile was negative and his glucose 6 phosphate was 12.7. His serum LDH was found to be high. All his laboratory parameters were suggestive of hemolytic anemia. Direct, indirect womb tests were negative. To rule out hemoglobinopathies, his hemoglobin electrophoresis was sent, which turned out to be normal. Hence, his red blood cell membrane studies and enzyme studies were sent and was carried out, which revealed a very rare enzyme deficiency, which is called as glucose 6 phosphate isomerase deficiency. It is a third most common erythrocyte enzymopathy following G6PD deficiency and pyruvate kinase deficiency. It is an autosomal recessive disorder, and only less than 50 cases have been described in the medical literature till date. The gene encodes G6PI is located on chromosome 19q13.1. G6PI dimeric form catalyzes the second step of Embedon-Meyerhoff pathway, which is described in the picture. Glycolytic pathway, which is the isomerization of glucose 6 phosphate to fructose 6 phosphate. It is a rate limiting step of glycolysis. The monomeric form is identical to the neuroleukin, which is a neurotropic factor that supports the survival of embryonic spinal neurons, skeletal neurons. Hence, it may rarely present neurological manifestations like muscle weakness, cerebellar ataxia, and mental retardation. So my conclusion is that glucose 6 phosphorus deficiency is a rare enzymopathy. Although it has no definitive management, splenectomy has been shown to play an important role in the reduction of blood transfusion frequency. That's it, ma'am.
Hi, Dr. Simran. Yeah, it's a good case study. Yeah. By chance, what are the other differential diagnoses you have thought about it? Because being 13-year-old male.
It is a 13-year-old male, so
Mhm.
it's a hemolytic anemia. So the
Your voice is cracking.
differential we had kept for an autoimmune hemolytic anemia, followed like another differential we had kept for hemoglobin cutting. Ma'am, should I turn off my video if you want?
Yeah. Sure. Yeah.
Okay, so first differential we had kept was an autoimmune hemolytic anemia. Hence, we had done a Coombs test. The second differential we kept was yeah. So the first differential was where we had kept was an autoimmune hemolytic anemia. Hence, we had proceeded with an direct and indirect Coombs test. The second differential was we had kept was hemoglobinopathies. Hence, we had proceeded with an enzyme studies. We had performed an HB electrophoresis. Then the third test we had done was G6PD. Hence, we had sent was a study that we had sent was glucose 6-phosphate dehydrogenase studies. So in that studies, we found out a glucose 6 isomerase deficiency, which is a very rare enzyme man we have found. And even in the literature, we have found was there are very few case reports that have been reported till date. So, yeah.
Okay. By chance, if it
Ma'am,
have
we
been
were
a
actually
female.
fortunate enough to see this case. Even in the hematologist that lifetime, he has seen only 2 cases till date. So, yeah.
Yes,
sir.
That's nice. So if
Even
it have been a
it is an
female,
autosomal recessive, so you can see this case. Yeah. Yes, ma'am. Ma'am. Yeah. Hello. Ma'am, your voice and it's not audible to me.
Ma'am, you're muted. Please unmute.
Yeah. Sorry. Yeah, it's fine. We can go to the next question. Any other questions from audience? And why you had done LDH in this case?
Hemolysis, it proves.
Okay. So
Marker
you want to.
hemolysis.
Okay, fine. Okay. Any other parameters you want to think about it for hemolysis? Like if you want to.
Ma'am, haptoglobulin. So it would also prove hemolysis. Even this patient's serum haptoglobulin was very low.
Okay. Why it is low in hemolysis alone?
Ma'am, haptoglobulin is a marker of hemolysis.
What does it do?
As in the mechanism for serum haptoglobulin.
Yeah.
Why is it low?
Yeah.
Haptoglobulin is, as in, it's a part of as in, I didn't get your question, ma'am.
Yeah. What is the role of haptoglobulin in our body? Why it is increased or decreased?
Ma'am, as it is.
What is its normal function?
The role of haptoglobulin is to it will be used. It is bound to the RBC. So whenever there will be a lysis of the RBC, it will be consumed. So that will lead to levels which will be decreased. So as a result of which there will be a low haptoglobulin level will be found whenever there will be a lysis of hemolysis. As in there will be a consumption of it. So.
Okay. Fine. Yeah. Okay. Good.
Yeah, thank you.
Thank you, Dr. Simran. Thank you. Yeah. Now, should we move on to the next participant now?
Yeah, sure. Yeah.
Okay. Dr. Jay Vignesh, are you there in the meeting?
And it's Jay Vignesh, right? It's not Dr. Savesh.
Yes. No, ma'am, he's not there in the meeting right now. I've tech contacted him. I'll get back to that soon.
Sure. Yeah.
Dr. Jay Vignesh, you can start presenting your screen now.
My slides are visible.
Yeah, it's visible. Yeah.
Can I start now?
And your time starts now. Yes.
Very good morning, one and all present here. I am Vignesh, doing my occupational therapy intern in Sri Ramachandran Institute of Higher Education and Research Institute. I'm here to present my poster titled as Use of Lighthouse Strategy on Activities of Daily Living for Subacute Stroke Patient with Right-Sided Unilateral Neglect, a single case study. My background information is unilateral neglect can occur when either the left or right hemisphere is damaged, the more frequently when the right hemisphere is damaged. In stroke patient, the persistence of the symptom lead to the inability to recognize object placed in a waiting. Okay. Symptom leads to inability to recognize placed in a space on the paralyzed side, as well as to difficulty in carrying out daily livings independently. Reported incident of right-sided unilateral neglect ranges between 21% and 68%. Unilateral neglect negatively affects the rehabilitation outcome regardless of the side in negative side in subacute location. My need for the study is there is no currently treatment that has been shown to improve only right-sided unilateral neglect. There is no guarantee that treatment for right or left-sided unilateral neglect are also effective for right-sided unilateral neglect. Future studies of treatment targeting right-sided unilateral are needed. My objectives are to find out the use of LITO strategy to reduce right-sided unilateral neglect and to find out the use of LITO strategy to improve activities of daily living. My methodology: a single case study was conducted during 2021 at Sri Ramachandra Hospital outpatient department occupation therapy unit. One subject was recruited for this study. Inclusion criteria: participants with the age above 18 years were recruited within 3 months after the onset of stroke. No significant cognitive deficit, with the film cognitive score ranging between 23 to 27. Bloomstone stages of form and 4 and above. Participant with right-sided unilateral neglect, a star cancellation test score of below 44, and participants who have difficulty in aerial skill with the film motor score ranging between 38 to 70. Exclusion criteria: another comorbid conditions, musculoskeletal or neuromuscular disability were excluded from my study. My outcome measures are star cancellation test. It is used for to assess the neglect, and functional independence measure. It is used for to assess the activities of daily living. Then what is LITO strategy? LITO strategy is the intervention which I used for my study. When the patients try to do something that requires them to see to both the right and left, I ask them to imagine they are LITOs like this one, and the therapist pointed to the LITOs picture and place it to the left or right of the patient within whichever visual field they were easily able to easily see. For example, if the patient have the neglect in the left side, we should place the LITOs image in the right side. Then the therapist said, imagine that your eyes and the head are like the light inside the top and sweeping all the way to left and right to the horizon to guide the ship at C2 safety. The patient were asked to then think about what would happen if the horizon. The therapist can introduce a simple table task requiring full scanning of left and right hemispaces. Patients were asked to find small three-dimensional object that had been placed across a 6-foot area in front of them. If they failed to see any of the object, they were asked to turn their head like a lighthouse left and right. Then my results, as this is a single case study, analyses are best interpreted through visual analysis of graphic data, star cancellation test, and that significantly increased to 49 in post-intervention measure. The scale, this score indicates that patient had reduction in unilateral neglect on its right side. Functional independence measure: the overall pre-intervention score of functional independence measure, motor subscale score was 45, which then it significantly increased to 80 in the post-intervention measure. The result support that the patient had improvement in the activities of daily living, such as self-care and transfer and locomotion. These are the two graphs which I supported my result. And the conclusion: the single case study aimed to investigate the use of LITO strategy on activities of daily living for subacute stroke patient with right-sided unilateral neglect. The result of the study indicate that the patient had better improvement in the ability to perform activities of daily living, such as eating, grooming, bathing, dressing, toileting, transfer, and locomotion following 9 sessions of intervention program. These are my important 5 references which I used for my study. Thank you.
Yeah. Hi, Jay Vignesh. Yeah, you did a wonderful study, and really, it's a new field for us, even. Yeah. Can you just, for the audience, can you explain a bit clear, like what is kind of unilateral neglect in a basic terms?
Right. It's about neglect on its right side, ma'am. Right side
Is it
unilateral
always on
is
right
a
side?
rare one.
Yeah, yeah.
No, ma'am,
Otherwise,
it is
just
common in left side.
yeah, yeah. So, can you explain the simple terms to the audience, because it will be very new to them? If you're telling them, is it like injury to particular cerebral cortex? The basic I'm asking. If you
Yes,
want to
ma'am.
tell
Yes,
to,
ma'am.
yeah, yeah.
If the lesion in the left side of the brain. The patient have the neglect in his right side, ma'am. So the patients were unable to identify objects in right side.
Is it like opposite side to the injury?
Yeah, opposite
right?
side the injury. Yes, ma'am.
Yeah. Is there any names for this?
Yes, ma'am.
Neglect. Yeah.
Unilateral neglect is otherwise called as unilateral spatial neglect. The name-spatial neglect.
Okay.
Isospatial neglect.
Okay. Why you choose only stroke?
Ma'am, because the prevalence of the stroke is higher than the other brain injuries, ma'am.
Okay. And you have included in the criteria like age group. Okay. Age group more than 18. So
yes,
how early you expect stroke? How early I can say, like maybe probably what are the cases which you have seen, like early stroke?
Early stroke, I have seen the infantile hemiparesis, ma'am.
Okay, you have mentioned 18 years and above. That's what I was asking. Like, is there any particular reason for that?
Yes, ma'am. After the 18 years, the prognosis was very good. So I have read some articles. In that article, they have mentioned above 18 years. In above 18 years, we will see more results than the pediatric age group, ma'am. So I would recommend in my future studies this intervention also can be used for pediatric unilateral neglect.
Okay, but you have mentioned above, right? Means it will not be included, right? 18 and
yes,
above is okay.
Yes,
okay.
ma'am. Yes, ma'am.
And you have taken some score, right? Which increased from 55 to 80. You told. Can you explain something about the score?
Yes, ma'am. Yes, ma'am. Ma'am, because score is in one of the study, they used 3 scales, ma'am. FIM and for unilateral neglect, star cancellation test, and a cognitive score. FIM score means at the time of patient admitting, the FIM score was 38 to 70, ma'am. So that I was particularly took that score for my inclusion criteria. For star cancellation test, it is lesser than 34 indicates the presence of unilateral neglect, ma'am. So I took that score.
What are the parameters which is included there? To make a score, you will have some
only I think the score only, ma'am.
The score needs some criteria, right? Then only you can score it.
Right? Yes, ma'am. It is average score to identify the disability level, ma'am.
Okay.
Based on that, we gave intervention and improvised the condition.
Okay. Okay, fine. Okay, Vignesh. Yeah.
Thank you, ma'am.
Yeah. Any other questions from audience?
Okay, then I think we should move on to the next participant.
Yeah, sure.
Thank you, Dr. Javignesh. Thank you, ma'am. Our next participant is Dr. Prakyat Chetty. Dr. Javignesh, can you please stop sharing your screen? Yes, Dr. Prakyat, you can start sharing.
Yes. Good morning, everyone. My name is Dr. Prakash Shetty. I'm a general medicine resident. Today, I'm presenting an interesting case of lepromatous leprosy, which presented as disseminated ulcers. Leprosy is a granulomatous infection which is caused by Mycobacterium leprae. It is a polymorphic disease which has a wide range of cutaneous as well as neural manifestations. And ulcer as such is not a common feature in leprosy patient except during reactional states such as and leuciophenomena or secondary to neuropathies. A 65-year-old male presented to us from rural Maharashtra, farmer by occupation, and was brought to casualty history of non-healing ulcers over bilateral upper and lower limbs, bed sore, decreased urine output, intermittent fever since 1 month. And patient also had history of left-sided hemiparesis 1 year back and was bedridden since then and had no other comorbidities. On examination, patient had multiple painless ulcers over hand and leg. There was right ulnar nerve thickening on examination, which was present without any associated tenderness. So biopsy of the ulcer was done from the medial aspect of the thigh, from edge of the ulcer, and the diagnosis of leprosy, lepromatous leprosy was done, and patient was started on multi-drug therapy for leprosy, and patient responded well with treatment with leprosy, MDT. Patient with leprosy rarely present as ulcerated lesions. These can eventually appear during reactional states, Lucio phenomena secondary to neuropathy, the latter particular on the plantar surfaces. This case did not have any clinical or histopathological evidence of Lucio phenomena or any reactional state. It is not clear why this leprosy lesion progressed to ulcer formation. The possible mechanism is as follows: a chronic and a poorly regulated subcutaneous inflammatory process that ultimately caused necrosis and ulceration. In lepromatous leprosy, both diffuse infiltration and Hansenoma can ulcerate due to inflammatory infiltrate containing large amount of bacilli within the macrophages. In turn, this can cause obstruction of superficial vein and therefore leading to ulcers. To conclude, ulcerated lesions should be considered as a clinical manifestation of leprosy, allowing early diagnosis and treatment, and therefore avoiding any development of disabilities and persistence of transmission chain of Mycobacterium leprae. And this case highlights the importance of recognizing ulcers as specific cutaneous manifestations of leprosy. I'm done with the presentation. Thank you.
Yeah, good, Dr. Pragya. Yeah, so it's a nice thing, and you're mentioning like ulcerated lesion should be made as a part of a clinical manifestation, right? So how common
Yes.
is this?
Ma'am, this is very rare. Typically, leprosy patient present to us with either a hypoaesthetic patch, hypopigmented patch. Now, ulcerated lesions,
Yeah.
which can be seen in reactional state, but this wasn't a reactional state. This was confirmed by biopsy, which concluded that it was a case of lepromatous leprosy, and as there was no any typical pathological changes of vasculitis found.
Okay, fine. Okay, so just can you, for a basic thing, can you tell that how does it results normally? Lepromatous leprosy, like what is the basic pathological issue? Like related to immunology, which kind of cells get activated, or I can say like, yeah, which group of cell? Which part of the immune system you want to say?
Cell-mediated immunity is more common in this.
Yeah, cell-mediated, yeah.
Typically, cardinal signs for leprosy clinical manifestation, there are 3 cardinal signs, which could be that, as I mentioned, anesthetic skin lesions, nerve enlargement, and plus on biopsy demonstration of M. leprae.
Okay.
But immunologically,
it's okay. You are already cell-mediated, so it'll be like T helper cell. Okay, fine. Yeah, good. Okay. So is it like what with tuberculoid leprosy? Is there any difference between these two?
yes, ma'am. Tuberculoid, for classification of leprosy, usually there is a Ridley-Joplin classification, which is divided into 5. And depending upon the bacillary load, it is divided. In our case, it was bacillary load of 5+ on Ridley scale. Therefore, it was classified as lepromatous leprosy. If the bacillary load was, for tuberculoid, it should be nil. If the bacillary load was nil, it could be classified as tuberculoid leprosy, as well as the clinical manifestation. As the patient had multiple ulcers, patient was classified lepromatous leprosy. If there was any single ulcer or manifestation, it could be classified as tuberculoid leprosy.
Okay, because it's almost diffuse, or you can see generalized lesions. Okay,
yes.
Okay,
yes.
Dr. Pragya. Yeah, good. Nice. Thank you.
Yeah. Thank you.
Thank you, Dr. Prakyat. Thank you, ma'am. We'll move on to our next participant. Dr. Ananya, are you in the meeting?
Yes, I'm here.
Okay, so you can start screen sharing.
Please.
My screen visible?
Yes,
Dr.
the screen is visible.
Hello, good morning to everyone. I'm Ananya Khurjekar. I'm a second year MBBS undergraduate student from BJMC Pune. So I present to you a case of locked-in syndrome, which is a rare neurological manifestation that is characterized by complete paralysis of voluntary muscles, except some that control the eyes. Case description: a 29-year-old female, gravida 2 parity 1, presented in the third trimester of her pregnancy with history of headache. Patient was a diagnosed case of chronic hypertension, and she was non-compliant to her hypertensive medication since the past 1 week. The headache was followed by a generalized tonic-clonic seizure, following which she was stabilized and then shifted to a tertiary care hospital in view of a prolonged post-ictal state. Upon arrival, an MRI of the brain was done, which revealed a pontine bleed, along with perilesional edema that caused effacement of the fourth ventricle. Also, there were multiple areas of hyperintensities in the frontal, parietal, and occipital regions, all of which was in favor of PRES, that is posterior reversible encephalopathy syndrome, which is common finding in eclampsia. Upon admission, the Glasgow score of the patient was 3. Immediate management consisted of levetiracetam for seizure control, magnesium sulfate and labetalol for hypertension, and tracheostomy was done, and a PEG tube was also inserted for feeding. Progress. Daily neurological monitoring of the patient was done, but that showed poor recovery. The brainstem reflexes like corneal reflex, gag reflex were absent. Patient was quadriplegic. She was not responding to painful stimuli, and the pupils were sluggishly reacting to light. Gradually, as the patient was weaned off of sedation and ventilation, and this is when the eye bobbing movements were noticed. So this is classical to pontine bleeds. It consists of vertical nystagmus with fast component downward and slow component upward. After that, the relatives also noticed that the patient was able to blink her eyes. Upon further investigation, we realized that the patient was blinking, occasionally blinking meaningfully to verbal commands. And thus, after removing all the supports, the systems were functioning normally. The patient was able to maintain her BP, her saturation, her cardiac output, but she was still quadriplegic and responding only with meaningful eye movements. And thus, it was diagnosed as a case of classical locked-in syndrome. Discussion. Recent studies have suggested that the diagnosis of LIS can take around 2.5 months on an average. And during this period, the patient might be considered unconscious. And thus, documenting cases of LIS is very essential to aid in its faster diagnosis. Here, we would like to highlight that it's a unique condition wherein the patients are conscious and their cognition is intact. And thus they can be involved in the decision-making process for their own healthcare management. And hence, I would like to emphasize here that the medical professionals should take efforts in such cases to preserve the autonomy of the patient by enabling them to communicate with eye blinking movements, which are conserved in most cases. Here I've also depicted a communication board for LIS, which can be used so that the patients can communicate using blinking movements. Thank you.
Yeah, hi, Ananya. Yeah,
Hi, ma'am.
really. I think it's a wonderful thing. Even I think you're in second year, right?
Yes, ma'am.
Okay, fine. It's a wonderful case, and yeah. So almost, I think you covered everything, and you told cognition is not affected in this kind of cases, right?
Yes, ma'am.
Why so?
Ma'am, because mostly cases of LIS have an occlusion there's some problem in the basilar artery, either an occlusion or an hemorrhage. But the posterior hemisphere, posterior part of the brain and the anterior are still communicating through the posterior communicating artery. Hence, blood supply in both those areas are intact. So cognition is intact. And
Okay, fine. And is there anything you told like through blinking they can communicate? Yes. Yes, obviously that's right, and that will be helpful, and even they can choose on their own decisions. Yes.
Yes, ma'am.
Is it any movement? Is there any difference? Like they can move vertically, they can move horizontally.
Movement of the eyes or limb movements?
Eyes.
Ma'am, only vertical eye movements are preserved and blinking.
Okay. Okay. Any idea bioanatomy? Why so?
Ma'am, for blinking, the oculomotor nerve nucleus is in the midbrain, and the midbrain is preserved. So that's why the patient can blink.
Okay, fine.
Because the lesion is mostly in the pons.
Okay. Okay. Yeah, blinking it's fine. Apart from that, why not horizontal and vertical? What is the difference there? You know the answer. I think, yeah.
Ma'am, I don't know exactly, but it just depends on the centers. The centers for those movements are outside the area of lesion. That's the basic. I'm sorry, I don't know in detail.
That's okay. That's okay. Okay. And you told like communication is either through blinking or through they're aphonic, right? What about the cure?
Ma'am, if cases like this are caused by some obstruction such as tumor, then surgery is an option. But unfortunately, in our case, it was a hemorrhagic stroke. That's
Yeah.
why only a palliative care approach was suggested, like with extreme nursing care and all. But currently, there have been advances in technology where BCIs, that is brain-computer interfaces, can be used. The patient can communicate. But such technology wasn't available in our setting. So our patient was on strict nurse care.
Okay, fine. Okay, good. I think if you are a book reader, then you can just go and search for some authors who blink, and then they communicate to the, I can say like the editors. So they written a story only just through his eye blinking. Yes, there is a famous author. Any idea about him?
Yes, ma'am, Stephen Hawking.
Yeah. Okay, fine. Okay, good. Nice. Thank you. Any other questions from anyone? Okay, Nanya.
Thank you.
Thank you.
Thank you,
Yeah.
ma'am.
So much.
Thank you, ma'am.
Thank you,
Now I would like to hand it over to Mona, ma'am, and take the session forward.
Yeah, just give me one, just 10 seconds. I'll just make the marks so that I should not miss it off.
Yes,
Yeah.
ma'am, you can take
Yeah.
it. Meanwhile, I request Dr. Akhil to be ready with his presentation.
Yeah, you can go ahead. This is Akhil, right? Dr. Akhil.
Yes.
Yeah. Okay. Fine.
Am I audible?
Yeah.
Good morning, ma'am. I myself, Dr. Akhilas, Junior Resident in Department of MS Otorhinolaryngology, Dr. SCGMC Nanded. My topic is malignant melanoma of nasal cavity, a rare case report. So moving on to my abstract, this is a poster presentation on malignant melanoma of nasal cavity in an elderly adult female who presented to a tertiary care hospital in Nanded district of Maharashtra. This was first described by Luck in 1869. Sinonasal malignant melanoma is a rare aggressive tumor associated with very poor prognosis. It accounts for 0.5% of all melanomas. Its incidence is slightly higher in men, in whites, and in over 60s. The risk factors and pathogenesis remain to be clarified. Symptoms develop slowly, therefore many patients are diagnosed late, reducing the overall survival. The risk of local recurrence and distant metastasis is very high. The diagnosis is based on anatomical and pathological and immunohistochemical findings. The treatment of choice is surgical resection, while radiotherapy and chemotherapy also serve to control local as well as metastatic disease. Malignant melanoma rarely develops in mucous membranes. Malignant melanoma of nasal cavity is an extremely rare tumor and is more aggressive than its cutaneous counterpart. Primary malignant melanoma of nasal cavity arises from melanocytes located in the mucous membrane. Only 0.5% of malignant melanoma arises in nasal cavity. Statistical data indicates that rhinosinus sinus and mucosal melanoma was reported in less than 1% of all melanin tumors and in 2 to 8% of all cancers developed in the nasal fossae and sinuses. Due to non-specific symptoms, patients come for medical expertise in advanced stages of the disease, which leads to poor prognosis. The average 5-yearly survival rate is only 20 to 30%. The objective of my study was to have a study on rare nasal mass in an adult female who presented to a tertiary care hospital. So moving on to my case history, the patient was a 68-year-old female who came to our ENT OPD with chief complaint of left-sided nasal obstruction since 1 month. which was associated with blackish foul-smelling discharge. She also complained of left-sided facial pain as well as headache. On examination, nasal examination showed blackish mass in the nasal cavity, which was arising from the lateral wall and extending up to the vestibule. The right nasal cavity was normal, and examination of neck showed enlarged cervical lymph node at level 2. So this is a figure showing preoperative photo of the patient. There is a black mass in the left nasal cavity, which was attached to the lateral wall as well as extending towards the vestibule of the nose. Now, investigations. Fine needle aspiration cytology was done from left-sided cervical node, which reported the possibility of melanoma. And then contrast-enhanced CT scan was done of paranasal sinuses. It showed heterogeneously enhancing soft tissue mass lesion in left nasal cavity, causing its near complete occlusion. And anteriorly, the lesion was extending up to left nostril and medially abutting the nasal septum, causing its rightward displacement, thinning and cortical erosion anteromedially. Laterally, it was abutting the left middle and inferior turbinates, causing the thinning. And of course, in the hospital, she was admitted under IP care and she was started on IV antibiotics and other supportive management. After all the routine investigations, anesthetic fitness, and the consent of the patient herself as well as the relatives, she underwent local excision of the mass endoscopically under general anesthesia. Intraoperatively, the mass was seen attached to the lateral wall of the left nasal cavity. I'll show the picture of that. This is an intraoperative picture, figure 2. The mass is seen attached to the lateral wall and it was seen extending towards the vestibule. The entire mass was removed and she was discharged on postoperative day 2 without any complications. Histopathological examination reported the mass to be malignant melanoma. Then she was followed up on a regular basis for 6 months and she showed no signs of any recurrence. This is a histopathological photo, figure number 4, showing spindle-shaped cells with granular brown melanin pigment. And figure number 3 shows the specimen removed after surgery. Moving on to discussion. Malignant melanomas are rare tumors of uncertain etiology and have no established risk factors or prophylactic measures. Only 0.5% of malignant melanomas arise from the nasal cavity. Due to their intracavitary location, most of the tumors are not diagnosed early. Primary investigations include X-ray of the paranasal sinus, which most often depicts blurring of the sinuses, and CT or MRI scans. Advanced radiographic techniques and prompt examination by nasal endoscopy can be very useful in detecting the tumor at a relatively early stage, which in turn can prove vital for better prognosis. If the tumor is aggressive, it needs radical surgery with broad safety margins, along with chemotherapy as well as radiotherapy. Recently, immunotherapy has been advised as a measure for control, but it has not proven beneficial for this tumor yet. Studies are under trial. Conclusion: malignant melanoma of nose is a rare tumor with aggressive behavior and poor prognosis. Being a very rare tumor, the high index of suspicion is needed for early diagnosis and detection of the tumor, which in turn can prolong the life expectancy of the patient. In my case, the patient presented early to clinical department and was treated promptly. Thank you. Yes, ma'am.
Yeah, Akhil. Yeah, good. Nice case history.
Yes,
Yeah.
thank you, ma'am.
And what are the differential diagnoses?
In an elderly female, first of all, the age of presentation is 68. So mostly in elderly females and in elderly people, we as ENT surgeons, we most often suspect case to be nasopharyngeal carcinoma.
Yeah. Okay. Fine.
It is the most common DE, but
Your voice. Yeah, Akhil, your voice is breaking. Yeah.
Yes, thorough clinical examination and endoscopic examination showed that there is no extension into the nasopharynx. It was only attached to the lateral wall of the nose, so which ruled out the possibility of nasopharyngeal carcinoma. Yes,
If it is by chance, okay, what are the things which you will say like it is nasopharyngeal?
Nasopharyngeal carcinoma most often presents most common presenting complaint of patient will be enlarged cervical lymph node, and it will be very much enlarged. And it will be stony hard. Most often patient presents late to the clinical OPD, clinical department with enlarged left or unilateral enlarged cervical lymph node. So
Okay.
then his or her primary complaint will be neck node enlargement, swelling in the neck. And then when we are going to detailed history, only they will tell about nasal symptoms.
Okay, fine.
But
Because
yes.
Yeah, tell me.
In my case, presenting complaint was not enlarged lymph node or swelling in the neck. It was unilateral nasal obstruction. And she also had a history of epistaxis.
Okay, fine. Okay,
Yes.
fine. So you mentioned something about the color, right? So
Yes.
is it giving by chance? Is it possible that you may think of some other diagnosis? being like an ENT? Color
Usually,
gives,
black color is usually seen in malignant melanoma. Then even in rhinosporidiosis, in advanced cases of rhinosporidiosis also, black color can be seen. But in rhinosporidiosis, we go on for detailed clinical history. Whether patient has history of swimming or taking baits in contaminated ponds or other water sources. So that will point on towards diagnosis of rhinosporidiosis.
Okay, fine. Okay. So where does this melanin come from? Being a biochemist, maybe I'm obsessed with that.
It is a neuroectodermal tumor. Malignant melanoma is a neuroectodermal tumor which arises from the melanocytes.
Okay.
Yes.
Okay, fine. So what are any newer chemotherapy which is available for, even though it is not showing that kind of
chemotherapy, ma'am?
Maybe for unresectable tumors or metastatic.
Yes. Actually, ma'am, dacarbazine. Dacarbazine is the only FDA approved drug for malignant melanoma.
Any other monoclonal antibodies?
Ma'am, verufenibib has been proven, and then imitinib has also been proven. It's also under clinical trial.
Okay, imatinib. Okay.
Imatinib.
Okay. That's okay. Okay, Doctor. Okay, nice. Thank you. Yeah, if anybody else wants to ask some questions.
I guess no. Thank you so much, ma'am. Thank you, Dr. Anil. So you can stop sharing your presentation. Yeah, moving on to the next presentation.
You can just.
Yes, I'd like to call Priyanka to present her poster presentation. I guess Priyanka is having some network issue, man. Can I share a screen?
Yeah. So you're going to call Priyanka, right?
Priyanka, yes.
Yeah.
Priyanka, you can start now.
Okay. A very happy morning to our respected judge and to one and all present here. There is no better feeling than the movement of life inside you. Today, we are going to present about the sensory development in the utero. The babies begin to learn about the world while they are in the womb. It is very important to know that their prenatal experience shapes their baby's expectation about life outside the womb and prepare them for life after birth. The formation of neurons begins very early in the embryo stage. The factors which have an effect on development of the baby, first is the neurons and the connections forming in the brain, and second is the state of happy and healthy state of the mother. It is very important to notice that the third trimester is the best time to stimulate baby's sense. When the babies are in the womb, their brain are still forming nerve connections, which are important for learning and memory formation. So during that time, you can just have a bond with the baby and teach your baby about the world which she or he is going to live. The prenatal sensory experience helps to shape the baby's brain. First is smell and taste stimulation. During the 28 weeks, the gestation and olfactory development occurs. The smell and the taste are being carried by the amniotic fluid, which the fetus absorbs through swallowing or mouth motion during the pregnancy. The fetus learns about the odor and the taste from the mother's diet. So the babies who experience nutrition and well-balanced diet before the birth are likely to accept variety of food after birth. Next is tactile stimulation. The fetus responds to the movement of the stimulation outside the womb from 26 weeks and reaches to the peak at 32 weeks. You can communicate with the fetus through tactile stimulation like patting, stroking the belly, rubbing the belly, and explain what kind of tactile stimulation that you provide. Touch stimulation helps in relaxing and reassuring of the baby. The baby responds to the tactile stimulation by changing its position, kicking, and pushing back. The benefits of tactile stimulation, first, it helps in faster weight gain, and next, it helps in lowering the stress hormones in the fetus. Next is music therapy. So, inner ear actually develops in 24 weeks. Lower frequency sounds crosses the mother's stomach and amniotic fluid better when compared to the high frequency sounds. Researchers show that the early exposure to music is beneficial for baby's behavior. So low frequency music like classical, jazz, and instrumental helps in relaxing of the baby's baby. Next is read and talk with the baby. Not only the fetus can hear, but they can also learn. Reading and talking, singing to the baby helps in development in language development and also helps in development of their cognitive. Conclusion. During each prenatal stage, the genetic and environmental factors can affect the fetus development. The developing fetus is completely dependent on the mother for his life. So the mother should take a proper care of her child, not only in physical development, but she should also consider her child's sensory and cognitive development. So I would like to thank for giving me this wonderful opportunity to present my poster presentation. Thank you.
Yeah, this is Priyanka, right? Yeah.
Yes, ma'am.
Yeah, good. Nice. So you're working in Ramachandra, right?
Yes, ma'am. I'm a student, final year student.
Okay, okay. So what are the therapies you're giving there for the patients?
Actually,
If the patient is coming in the first, not a patient, I can say, a pregnant woman is coming in the first trimester. So what
no,
are the
ma'am.
things? Yeah.
Actually, we as an occupational therapist, we still have not deal with any gynecologist. Any mothers during her pregnancy. We are still starting up our intervention to provide for mothers in Ramachandra Hospital, ma'am. So it's just an idea for providing tactile stimulation and auditory stimulation for the fetus inside the baby. Because as an occupational therapist, we mainly deal about providing sensory stimulation to the babies for better development, ma'am.
Okay, fine. Okay, okay. So do you prefer like some special cases? To whom you will be like telling for the tactile stimulation, even how it is going to be beneficial? Which part of I can say like patients or?
Ma'am, it can be provided to a normal mother itself, ma'am, because generally it's going to develop the babies in a better way. It helps in better development of the baby, ma'am.
Okay, fine. So maybe it is so generalized. So I'm asking you, like you told, like listening music therapy and all those, maybe around 28 weeks, something, right? So even you would have heard like so many of them, they will be hearing music and all those things, right? So what is the mechanism behind it? What is the clinical mechanism? Like any pathway is there? Especially with musical therapy, if you go ahead it. Hello.
Yes, ma'am.
Yeah. Or when the mother will be there, if a pregnant woman is there, being a first pregnancy, when she will be feeling the movements of the baby, at what month or what weeks do you expect
24 or 26 weeks.
Okay, it's around 20 weeks. Okay, fine. So what might be the pathway? Is the or any other not only for music, any other tactile stimulation? Is there any pathway related to that? Or you want to tell some downstream events, what is happening?
Ma'am, it is done by lemniscal pathway.
Mm-hmm. For
proprioception, ma'am.
Okay.
And touch.
Okay. So you're telling like it is getting transmitted through amniotic fluid and then it reaches the baby. Okay. Yes, so does it have any effect if a mother is having oligohydramnios, like less of amniotic fluid? Because you're telling like all these things are getting transmitted through amniotic fluid. So if by chance some of the mothers, I can say they will be having less amniotic fluid. So will it have a difference among these two? And yes, mother with, still it is going to be beneficial or?
Yes, ma'am, it will be beneficial for them.
Okay. So irrespective of medium, you're telling like, okay, fine. Okay, fine. Good, Dr. Priyanka, right? Yeah. Any other questions from anyone?
Thank you so much, ma'am. So
thank you, ma'am.
Thank you, Priyanka. So I'd like to call upon next presenter, Dr. Vidvat Vijay, to present.
Good morning, Anmol. Am I audible?
Yes, yes, you are
Yeah,
on.
yeah,
Okay, 1 second. I'll just share my screen.
yeah. Just give me 5 seconds. Just
Yeah,
5 seconds.
sure,
I'll
ma'am,
just put
sure.
them. Yeah, sure.
Is my screen visible? Screen and audio.
Yeah, audio is, I'm hearing your audio, but your screen, I think, yeah, it's visible.
Yes, ma'am. Okay.
Yeah, you can go ahead.
Good morning, one and all. I am Vidwat Vijay, a second year medical student from MJIMS Sevagram. And today I'm here to present a rare entity as the endometrial carcinoma metastasizing to the kidney. Endometrial carcinoma is a common gynecological malignancy, typically metastasizing to the aortic lymph nodes, vagina, peritoneum, and the lungs. Metastasis to the kidney is uncommon and is reported in less than 1% of the cases. A 64-year-old female presented to us in the surgery department with pain in the left flank for off and on for 1 year. It was insidious in onset and progressive in nature. She was also a known case of endometrial carcinoma and had undergone surgery and chemoradiation for the same 3 years earlier. On examination, the general and systemic exams were normal and not very significant. While knowing her history and her complaint, we suggested investigations on the same. And therefore, our first investigation was USG whole abdomen. As we see in the first figure, the photograph suggests pelvic alysial dilation and paper thinning of the left renal cortex. This was suggestive of a non-functioning left kidney with gross hydronephrosis. A surgery was planned and left radical nephrectomy was performed. The gross specimen that was obtained measured 11 by 6 by 4.5 centimeters. The external surface was irregular. The cut surface showed multiple lesions and a single solid area of the measuring again 4 by 3 by 2.5 centimeters was seen. Microscopically, as we view the second picture, we see that the renal parenchyma shows a metastatic deposition of endometrioid carcinoma. In order to confirm our diagnosis, we performed immunohistochemistry. On performing immunohistochemistry, we saw it was positive for cytokeratin and HER2 mutation. Then it was negative for vimentin, and the tumor cells were negative for vimentin, ER and PR receptors, which is seen here as focal negativity. After which, what are the points that we should discuss? Endometrial carcinoma is a common malignancy as stated before. It accounts for 2 to 3% of all gynecological malignancies. The typical metastasis sites for endometrial carcinoma include local pelvic recurrences, para-aortic lymph nodes, peritoneum, and the lungs. While atypical sites are not usually taken up by endometrial carcinoma and these are usually taken up by aggressive forms like clear cell carcinoma or serous cell carcinoma. The atypical sites also include here extra abdominal lymph nodes, the liver majorly, adrenal glands, brain, bones, and soft tissues, hence excluding renal, which is why the literature is low. Secondary or metastatic carcinoma to the liver from gynecological malignancies are reported in less than 1% of all autopsies, and our patient had it in situ. Usually, a good renal function is maintained in majority of cases. In conclusion, I'd like to say renal metastasis from primary tumors are very rare. A majority of patients present with good renal function, while histological and pathological histology and immunopathology are the pivots for diagnosing such conditions. Our case was a unique one as the patient presented with a non-functioning kidney on the contrary to majority of cases, and this was detected or was seen in situ in the patient, and this was primarily due to metastatic endometrial cancer. Thank you very much for the opportunity.
Yeah, hi. Okay, nice case history. Fine. And
Yes, thank you, ma'am.
it told, if by chance the patient has already underwent hysterectomy and all those, by chance, if she
Yes,
is
ma'am.
presenting for the first time, how does the patient present for endometrial carcinomas? Like, what might be
Ma'am,
the symptoms?
Ma'am, for endometrial carcinoma, depending on the type, which is type 1 or type 2, they will
Okay.
present with an abdominal mass, which will be usually a pelvic mass, and there will be, as it is a malignant tumor, there will be hemorrhage, which will be seen through the vaginal canal, and these will be the presentation of the patient. But she presented earlier in another hospital, therefore we do not have a history of that hospital, and it was done 3 years ago.
Okay. It's bleeding PV, right?
Yes, ma'am.
Okay, fine.
Bleeding PG.
Okay, fine. Okay. So you told endometrial carcinoma. Moving to this a rare place, right? What is Lynch
Yes,
syndrome?
ma'am.
Have you heard about Lynch syndrome?
Yes, ma'am. I've heard about Lynch syndrome.
Yeah, what is it?
Ma'am, it is I
It's
at the
okay. It's okay.
moment do
Fine.
not
No problem.
remember.
No problem.
Sorry, ma'am.
That's okay. That's okay. No problem. Okay, fine. So if the same patient, okay, if it doesn't know there is no primary malignancy, what are all the diseases you will think? If a patient is presenting with isolated kidney lesion, what are
Ma'am,
the
gross
possibilities?
hydronephrosis due to obstructive pathology can be suggested, because due to left renal pain, therefore, also as she was a female, due to the short ureter, there could be ascending pyelonephritis that could have
Mhm.
caused the renal angle pain,
Okay.
which was involving the kidney. Uh,
You told women 10 positive, cytokeratin positive, right? What does it mean? Women 10 positive means what?
Ma'am, Vimentin positive is my Vimentin negativity was seen in our tumor. It is for mesenchymal tumors and not for epithelial tumors, while cytokeratin is present in the epithelial cells, and therefore positivity is seen in such cases.
Okay.
Yes, ma'am.
Okay, doctor. It's your student, right? With what? Yeah.
Yes, ma'am.
Thank
Thank you,
you.
ma'am.
Yeah. Yeah. Thank you. Any other questions from anyone?
Thank you, ma'am. Thank you, doctor.
Yeah, thank you.
We have missed Dr. Sandeep, who is in the next second slot. So can we call him now?
Dr. Surveys, right?
Sandeep Service. Yes, ma'am.
Yeah. Sure. Just give me maybe a minute or so. Just I'll mark the preview.
Sure.
Yeah. Just can you wait for a maybe half minute? Just I'll finish the markings.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Dr. Sandeep, you can just zoom in out.
Yes, ma'am. Good morning, ma'am.
Yeah.
Hello.
Yeah. You can.
Good morning, ma'am. Myself, Dr.
Good morning.
Sandeep Survase. I'm from VPS Medical College, surgery resident. My topic is persistent Mullerian duct syndrome, a rare case report. Persistent Mullerian duct syndrome is defined as the presence of Mullerian derivative in 46XY patient. PMDS patient is outwardly male. Urethra opens at the tip of the penis. Symptoms PMDS is discovered at surgery motivated by cryptorchism. The incidence of testicular cancer in PMDC is estimated around 18%. Material and methodology: single case of study of persistent Mullerian duct syndrome in a tertiary care hospital, Nashik, in 2021. We are diagnosed as a persistent Mullerian duct syndrome on laparoscopy and confirm on histopathology report. A 13-year-old male with complaint of non-palpable right testis and testicular-like structure palpable in left scrotum, that is undescended testis. On examination per abdomen, soft non-tender. Scrotal examination, testis not palpable in the scrotum. External genital area also well developed. On USG, Right testis not visualized in right scrotal sac, and descendant left testis. After well-informed consent, surgical procedure is done. Diagnostic laparoscopy was done, in which uterus and two gonads are seen in the abdomen. A biopsy specimen was taken. From each biopsy specimen report, the gonad showed seminiferous tubule, which showed primary spermatogonia, secondary spermatogonia in various stages of development. The interstitium showed Leydig cell, no ovarian tissue identified. Section labeled as uterus showed narrow tubular endometrial gland surrounded by endometriostoma. The deeper tissue showed presence of myometrial smooth muscle fibers and a few thick walled blood vessels noted in the myometrial tissue. Finally, ma'am, laparoscopic right orchidopexy with left orchidectomy was done, and I would be thankful to giving wonderful opportunity to presenting this poster. Thank you, ma'am.
Yeah, Dr. Sandeep. Good. So,
Yes, ma'am.
what is the mode of inheritance of this PMDs?
Ma'am, this is a rare situation or condition.
Yeah. So, what is the genetic mode of inheritance?
Hello.
Yeah. Tell me. It's okay.
40,
It's okay.
okay.
Tell me. Yeah.
46 is why.
Okay, that is a chromosome number, right? Okay, fine. It's okay. Fine. What is the normal function of mullerial duct?
It develops a female like structure.
Okay. Have you heard about any hormone? It's like AMH, anti-mullerian hormone, right? What is the
Yes,
role of
ma'am.
that? What do you expect in this patient? The level should be?
In male patient, anti-mullerian hormone regresses the structure of female structure, and it develops male genitalia also.
Okay. So what do you expect in this patient? Same PMDs?
Ma'am, this patient in future develop a seminoma to avoid carcinogenic conditions. We will do laparoscopic orchidopexy with left orchidectomy.
Okay. So you told there will be a presence of uterus, fallopian tubes, and all those, right? So what do you do for this patient? Apart from treating your unders and the testes, is there anything else you can do?
Ma'am, endocrinologist opinion also do. We will do. We will give patient from outside hormone therapy to
what does the hormone therapy do?
Secondary sexual character.
Okay. Okay, fine. Yeah. Okay, Dr. Sandeep. Yeah. Thank you.
Okay, ma'am. Thank you. Thank you.
Thank you so much, ma'am. Thank you, Dr. Sandeep. I'd like to call the last
Thank you, ma'am. Thank you.
who's the slot with Dr. Meghna now. Can she present now?
Am I audible?
Yeah. You're audible.
Can you please share my document? Good morning, everyone. I'm Dr. Meghana Rao, a third-year medicine resident from GMC Nanded, and my guide is Dr. Kapil More sir, an associate professor at GMC Nanded. I'm here to present a rare case of panhypopituitarism with Sheehan syndrome. Introduction. Sheehan syndrome is postpartum hypopituitarism caused by necrosis of the pituitary gland. It is usually a result of severe hypotension or shock caused by massive hemorrhage during or after delivery. Patients with Sheehan syndrome have varying degrees of anterior pituitary hormone insufficiency. Its frequency is decreasing worldwide nowadays, especially in the Western world due to advances in obstetric care. However, it is still persistent in the developing and underdeveloped countries. It is a rare cause of hypopituitarism. It often evolves slowly and hence is diagnosed late. Here is my case report. A 40-year-old female patient presented with complaints of generalized weakness, depressed behavior, anhedonia since 2 months, and 2 episodes of generalized tonic-clonic convulsions and fever since 1 day. She gives no history of headache, vomiting, blurring of vision, or double vision. No other comorbidities. History of hypertension during pregnancy followed by lactational failure was present, with amenorrhea since last childbirth. The patient on presentation had a low volume pulse with bradycardia, a 70 systolic BP. She had bradypnea with a respiratory rate of 12 cycles per minute, dull, depressed, aged look with wrinkled skin as depicted in figure number 1, with cold, clammy extremities. She had non-pitting pedal edema. The pedal edema is depicted in figure number 2, with clubbing. On systemic examination, she was conscious disoriented with absent deep tendon reflexes and no neck stiffness. Routine investigation showed a very low random blood sugar level of 45 milligram per deciliter. All other routine investigations were normal. CT brain fundoscopy were normal. A thyroid function test revealed low T3 and T4 but a normal TSH. Early morning, 7 a.m. serum cortisol was reduced and serum FSH was reduced. A contrast enhanced MRI brain was done, and it was suggestive of empty cella with minimal residual pituitary showing heterogeneous enhancement. Also with posterior reversible encephalopathy syndrome, hence a diagnosis of panhypopituitarism, Sheehan syndrome was made, and treatment started accordingly. On investigations, her complete hemogram, liver and renal function tests were normal, CT brain fundoscopy were normal, her random blood sugar was very low, and repeated blood sugar values were always low. ECG was suggestive of sinus bradyarrhythmia with ventricular bigeminy as depicted in figure number 3. Her TFT, as I said in the earlier, was T3 and T4 were low, but TSH was in the normal range. Serum cortisol and FSH was low. Prolactin was in the low normal range. Repeat CT brain was suggestive of posterior reversible encephalopathy syndrome, hence a contrast-enhanced MRI brain was done, which showed severe reduction in the height of pituitary gland with CSF filling rest of the cella. Empty cella with minimal residual pituitary showing heterogeneous enhancement with press, as depicted in figure number 4 and 5. ABG was suggestive of respiratory acidosis with hyponatremia. Conclusion, hence Sheehan syndrome presents with hypopituitarism. Its clinical features are often subtle and years may pass before the diagnosis is made following delivery. History of lactational failure and cessation of menses are important clues to diagnosis. Early diagnosis and appropriate treatment are important to reduce morbidity and mortality of the patients. Thank you.
Yeah, hi, Dr. Meghna.
Hello.
Okay, that's good. And yeah, so nice case and fine. So in this case, why you have hypoglycemia?
Hypoglycemia is because the ACTH, because of the ACTH deficiency, serum cortisol is on the very lower end, which is why there is hypoglycemia, as well because of hypothyroidism, serum cortisol. The patient had a presentation of mixed edema coma.
Okay. Okay.
Yeah, so that is when there is hypoglycemia.
Okay, fine. Okay. Can you just tell something about the TFT findings, thyroid profile findings?
Yeah, her T3 and T4 were in the normal range, but T3 and T4 were reduced, but TSH was in the normal range, which is seen in secondary hypothyroidism.
So why do you expect normal TSH in this patient? Even though there is a, yeah.
It was
Where does the TSH come from then?
TSH comes from the thyroid gland itself.
I think your voice is breaking. It's okay.
Am I audible?
Yeah. Now it's audible. Yeah.
TSH comes from the thyroid gland, and here there's no problem in the
TSH, are you sure? It comes from thyroid gland?
TSH comes from the pituitary.
Mm-hmm. Okay. It's okay. Sometimes this happens. Okay. Okay. Have you heard about a term called macroprolactin?
Macroprolactin, no.
Okay, fine. Okay, Dr. Meghna. Nice case status. Okay, thank you.
Thank you so much, ma'am, for your patient judging for all the presenters. I wish all the presenters being there knowledge from.
Yeah, thank you. It was nice, really. I'm also learning some new terms, and even the occupational therapy and all those. There are very nice presentations from your side. Thank you, and all the best for every participant and the whole team who organized this. Yeah.
Thank you.
So much. We also have with us Dr. Shubham Gupta, sir. He's the head of the scientific committee. Over to you, sir.
Hello, ma'am. A very good morning, ma'am. How are you?
Yeah, good morning. Thank you. Oh, yeah, you're the one. Yeah, good.
So sorry, ma'am. I couldn't join in for today's session because I had hospital duty, ma'am. But
No
I was
problem.
there at the end of the session, and it was really enlightening to see the kind of questions you're asking. Those are all basic questions which everyone should know. And thank you so much, ma'am, for joining in for this session, sparing your precious time with each one of us. Enlightening the whole presenter about the subject, how it is done, what it is done, and why it should be done. That is need of an hour, ma'am. And I know like your schedule is a bit packed up, but I would extend a sincere gratitude to you, ma'am, for joining and gracing this occasion by your presence. I am very much sure that all our presenters have learned a lot from you, ma'am. And at the end, I would also like to say, is there anything, ma'am, which you would like to tell to all our presenters, which they should keep in mind in future while presenting any papers or posters?
Yeah, thank you. Thank you so much for your kind gesture. And even really, it's a privilege from my side to just know the young minds, right? Yeah, I think, yeah, it's good to know that even second year students, they have started presenting very nice cases nowadays. So yes, which was not happening in the previous decades. It's really wonderful to see them. And I think they're doing in a very good way. And obviously, they can present even I think in many other forums, whatever cases they are seeing, even not even rare, they want to wait for the right cases. Whatever they feel like right from the basic, they can just start presenting in various platforms, and that will obviously increase the knowledge. So, and I think I have to really thank for the team who organizes this, especially focusing on all the students and residents. So, thank you.
Thank you so much, sir. Ma'am, a special thank to our excellent and talented moderators for the Tanishka and Mona, ma'am. They have been consistent from past 3 days, ma'am, and they have been moderating sessions very efficiently and very nicely without any interruption. They are very cordial with all the presenters, ma'am. So thank you so much, Tanishka and Mona, for taking out the session very smoothly. And again, once again, a special thanks to Dr. Maheshwari, ma'am, for gracing this occasion, ma'am. I definitely like to connect, rather, we would definitely like to connect with you on other several occasions as well. We are planning conferences in future, ma'am. Thank you so much, Tanishka and Mona. Over to you.
Thank you.
Thank you.
Thank you, sir.
Ask all the presenters to switch on the video for a click, for a group photo.
Do we have Shreya, ma'am, Shiv sir, or Akshay sir over here?
Shreya, ma'am.
Shreya, ma'am, can you hear us? Okay, no issues. We'll move on to Mona. You click the photograph?
Yeah, I'm taking.
Okay.
Perfect. Done. Thank you so much, ma'am, for your time.
Thank you so much, ma'am. Thank
Thank
you
you
so
all.
much.
Have a
ma'am.
great day. Yeah. Bye.
Same
Yeah.
to you, ma'am. Bye.
Thank you, ma'am. Bye.
You have a beautiful smile and you have really a good positivity. Yeah. Keep it on. Yeah. Thank you.
Ma'am, this was for me.
Yeah. I don't want to say that your smile speaks. And she was like, really good. Thank you. Thank
so
you
much.
for
That's so
everyone.
sweet of you, ma'am. Thank you so
Thank
much.
you. Yeah. I'll send the marks through mail or
Sure.
whatever. Yeah. Yeah.
Sure,
Okay.
ma'am. Thank you so much, ma'am.
Yeah.
Mona and Tanishka handled the session very well. Congratulations once again.
Thank you.
Thank you, sir. Piyush sir, should we stop the recording in the live stream now?